Welcome to Chapter 6, Resistance Exercise for Impaired Muscle Performance. So muscle performance is the capacity of a muscle to do work, and so we look at work as being force times distance. How much force can a muscle generate and how much distance can it move through? Resistance exercise is an activity in which dynamic or static muscle contraction is resisted by an outside force applied manually or mechanically. The elements of muscle performance are the things that we're going to assess in a patient, but also try to target to improve in a patient. So we're looking at strength, power, and endurance of a patient's muscles. Strength is the force-producing capacity of the muscle, and we typically want to look at manual muscle testing strength in individual muscles, but also the functional strength. What are they prevented from doing because of a strength deficit? Power is the work produced by a muscle per unit of time, and it looks at the rate of performing work. And so we think of anaerobic versus aerobic muscle activity when we look at power. Endurance is going to be the ability to perform repetitive or sustained activities for a prolonged time. Strength training exercises have been shown to have a crossover effect for endurance training, but not the other way around. So we can see an improvement in endurance from strength training exercises, but we don't necessarily see an improvement in strength from endurance-based exercises. So if we look at strength a little more closely, strength training is using muscle force to raise, lower, or control heavy external loads for a relatively low number of reps over a short period of time. Functional strength relates to the ability of the neuromuscular system to produce the appropriate amount of force during functional activities in a smooth and coordinated manner. So a person who is strong is not necessarily functionally strong because functional strength requires coordination as well. The most common adaptation to strength training is an increase in the maximum force-producing capacity of the muscle, primarily as a result of neural adaptations, which are the first to occur, and increased muscle fiber size. There are a few principles that you need to know in relation to resistance training, and the first of those is going to be the overload principle. The overload principle says that to improve muscle performance, there must be a challenge to perform at a greater level than that to which it is accustomed. So in order to make a muscle stronger, we have to apply resistance that challenges the muscle beyond its normal strength. Application of the overload principle can be seen in the intensity of the resistance exercise, so how much force or resistance we're having them work against, the volume of the exercise, what quantity we're having them do, or the context of the underlying pathology, so what other factors are contributing to the muscle stress and making sure that we target the overload at the appropriate level. The said principle, or the specific adaptation to impose demands, is an extension of Wolff's law that, remember, says bones get stronger the more we stress them, tissues get stronger the more we stress them, and so it relies on a specificity of training. If we want something to get stronger in a specific manner, we have to train exactly in that manner, or at least related to that manner. There's a transfer of training, and a cross-training effect in strength training will increase strength and have some impact on muscular endurance, but not aerobic capacity. So we get a limited effect of strength training on endurance, but it doesn't necessarily affect aerobic capacity. If we want to see an improvement to aerobic capacity, such as a goal of being able to run further or faster, we would have to target aerobic training specifically. In order to increase muscle power, the resistance exercise must challenge both the force and speed capability of the muscle. So remember, power is time dependent or rate dependent. We can increase strength by just focusing on the force, but in order to increase power, we have to focus on force and speed of the muscle. And the reversibility principle tells us that detraining can happen, that if we don't use muscles, that they will get weaker, they will have less endurance and less power. Factors that influence tension generation in normal skeletal muscle can include the energy stores and blood supply. So how much energy is available within the body that the muscles can utilize for activation and contraction, and what is the blood supply to deliver that energy and oxygen to the muscles that they need to function? What does that look like? Fatigue can also play a factor in the tension that a muscle can generate. So we can see local fatigue or muscle fatigue, and that'll present as demonstrating slowing voluntary contractions, reporting uncomfortable sensations or pain in the muscle. The patient can demonstrate shaking or trembling of the contracting muscle, then inability to complete the full range, especially as they perform repetitive motions, and the use of substitutions. We can also see fatigue in the cardiopulmonary system with generalized fatigue that can show up as shortness of breath. And every person has a threshold for fatigue. And so it's important as therapists to ask ourselves, how can we determine this? And I think that that has to be a patient dependent answer, but we can look at what their overall capacity is, monitor for what they can achieve just short of that capacity, and see how far we can push them to where they are still able to recover and perform within another set of exercises or a muscle group being targeted or another treatment session. Quick little question time here just to check your knowledge. So, which of the following resistance training techniques is most effective for increasing muscular strength? Is A, performing high repetitions with low weight, B, utilizing isometric contractions, C, implementing progressive overload with increasing weight, or D, focusing solely on eccentric muscle contractions? So the answer for this one is C, implementing progressive overload with increasing weight. Progressive overload, which involves gradually increasing the weight or resistance over time, is a fundamental principle of resistance training for improving muscular strength. This technique challenges the muscles to adapt and grow stronger over time. Now, there may have been some of you who were tempted to pick the eccentric muscle option or eccentric contractions only option, and this is a board style question, so where you're going to have two answer choices that both seemingly are right, but which is the best one? And we can't exclusively rely on eccentric muscle contractions to see strength gains. While we get greater strength gains from eccentric contractions, especially early on, they're not the only way, or it is not the way to maximize strength gains. The way to maximize would be implementing progressive overload with increasing weight. Signs and symptoms of muscle fatigue can be found in box 6.2. I'm not going to read them off to you because we just reviewed them a few minutes ago in this lecture, but it's important to note that when patients are demonstrating these signs and symptoms of muscle fatigue, that we have to allow the patient to rest the muscle group and switch to performing an alternate exercise for a different muscle group. So that way we're not losing therapy time, but we're also not overworking our patient and causing them to put themselves at risk for injury because they're not allowed to have time for recovery from that fatigue. Continuing to look at factors that influence tension generation in normal skeletal muscle, we can also include recovery from exercise. Things like lactic acid buildup within the muscle can decrease the amount of tension that the muscle can generate when the muscle is recovering from exercise. We can also look at age, looking at box 6.3. You can go through there for some more specifics, but essentially strength is a little bit like a bell curve to where we progressively get stronger as we grow older and we develop, and then as we get into young and middle adulthood, our strength starts to decline, and late adulthood we have more substantial declines in strength. We can also look at psychological and cognitive factors. The amount of attention that a person is paying to the activity that they are trying to do can influence the amount of force that they can generate with the muscles, and their motivation to perform the task as well as the feedback they get about their performance can affect how much force they can generate in a muscle. So what happens within the body when we apply resistance training or resistance exercises? We see physiological adaptations, and in the nervous system, we get those as the first to happen. So neural adaptations are the first to occur, with the first 6 to 8 weeks of strength gains due to neuromuscular changes, and this involves improving signals from the brain to the neuromuscular junction, improve firing within the muscle itself, improved recruitment of motor units. All of those things are the neural adaptations that are the first to happen. Then we start to see skeletal muscle adaptations where we can see hypertrophy, which is an increase in the muscle size. Hyperplasia is going to be the increase in the number of muscle cells, and muscle fiber type adaptation, depending on the training that we are using. We can transition muscles from type 1 to type 2 based on the demands of the activity. We can also look at cardiopulmonary adaptations, but remembering that there's minimal crossover if we're not utilizing aerobic exercise. So there's moderate crossover on endurance, but true cardiopulm gains require specific aerobic training and aren't something that we can see a whole lot of from resistance training. Vascular and metabolic adaptations demonstrate improved withdrawal of oxygen from the blood and utilization of the oxygen for decreased demands. So not only are we getting likely improve circulation to the area, but when the blood is coming past, the muscles are able to draw the oxygen out more efficiently, and the oxygen that they do have, the muscles are able to utilize more efficiently. So if there is a period of an oxygen deficit, the muscles are still able to function at the appropriate level. We also get adaptations of connective tissues where tendons, ligaments, and connective tissue in the muscle increase in strength, and this is a little bit of that extension of Wolff's Law. And we also see a bone mineral density increase. So resistance training can help patients with osteoporosis when applied correctly. When applying resistance exercise, there are several factors that we need to look at, and you can take a look at those in box 6.4 if you would like. We'll go through them here. But alignment and stabilization are going to be pretty substantial factors because we need to make sure that we have the body segments aligned appropriately to get the muscles working in the right way in order to see the strength gains that we're trying to achieve. We also need to make sure that we have stability in the proximal joints before more distal motion so that we don't cause injury proximal. A joint must be properly aligned to achieve the appropriate muscle activation, and so an example of this is going to be glute med. If we look at patients doing hip abduction exercises, a lot of times that leg tends to drift into hip flexion and abduction because of compensation from the tensor fasciae lata. That's not targeting glute med and won't result in strength gains in glute med. We have to ensure that the side that we're trying to activate is staggered back just slightly in a hip extended or at least hip neutral position to go into hip abduction so that we get appropriate activation of our glute med. We also want to target larger muscle groups first to help promote proper alignment when targeting smaller muscle groups. And this is looking at gross movement versus fine movement. We have to have a grasp and a solid foundation of our gross movements before we can perfect our fine movements, and so we need to target larger muscle groups first. Alignment and gravity are also important. We need to make sure that we are aligned either against our resistance or against gravity as appropriate so that we are actually getting the resistance that we need and not having gravity assist us in that. Stabilization is important, whether that's external stabilization, utilizing holding onto a table for balance, or having the wall help maintain posture. Whatever the case may be, having something outside of the body to provide support is important for appropriate muscle activation. And then we also have the internal stabilization as the goal that we're trying to get patients to achieve with appropriate muscle activation so that they have functional carryover. We'll also look at determining exercise intensity at submax versus maximal exercise loads. In therapy, most of the time we're going to be utilizing submaximal loads because of risk of re-injury. Increasing pain can indicate that the exercise is too intense, and so we need to decrease the intensity but not stop altogether. We don't want pain to be something that makes us say, oh my god, I have to panic and stop. We want to respond to patients' pain but still push them to achieve the therapeutic goals. The initial exercise load and documentation of training effects can be determined by looking at the repetition maximum. So what is the maximum amount that a person can lift for a fixed number of reps? Most commonly, we'll talk about a 1 rep max. So what is the maximum weight that can be lifted by a specific muscle group or a specific motion for 1 repetition that at that point the muscle's at its fatigue and it cannot do a complete repetition the second time. And we'll use 1 rep max as kind of a baseline of what percentage of resistance we want to utilize. 1 rep max are hard to use in a therapy setting, especially if somebody's recovering from injury. And so alternate methods that we can utilize are, instead of how much force can you move one time, we can look at how many times can you move a set force. And so we can look at, if somebody's doing long arc quads, how many times can they go through complete range of motion with a 2-pound weight on their ankle, and that's their fatigue point. And so we can also use that as a baseline. The important thing is that we're understanding our exercise prescription, especially for intensity, has to be related to what the person's maximum potential is. The recommended training zone from your textbook is 40 to 70% of the patient's 1 rep max. When we talk about exercise volume, we're talking about reps and sets, or our repetitions and our sets. And we're going to determine our repetitions and our sets based on what our patient's needs are. Typically, if we are having a higher exercise intensity, we're going to do fewer repetitions. With a lower exercise intensity, we'll do more repetitions. But it also is important to understand whether our goals are to increase strength or increase endurance, or even sometimes to increase power, and direct our exercise prescription towards what's most appropriate for those. So if we're doing 75% of our patients 1 rep max, we might have them do 10 reps. If they're doing 60%, we might have them do 15 reps because they're at a lower intensity. They should, in theory, be able to do more repetitions. It's important to know that these are recommendations, not requirements, and every prescription that you give for every exercise for every patient is going to be individualized to what that patient is capable of and what the goals for that patient are. Our sets are going to be how many times are we going to perform that number of repetitions. 2 to 4 is the most common, but the research shows that 1 to 6 yield positive training results, and so again, it depends on what the patient's needs are, the patient's status, and if the goal is for strength or endurance gains. This slide gives you some recommendations for where to start as new PTAs, new clinicians trying to understand how to develop your exercise prescriptions. Again, remember these are recommendations, not requirements, and so you're going to individualize it to your patient. But if our goal is to improve muscle strength, then we're going to have maybe 60 to 80% of the 1 rep max for 8 to 12 reps over 2 to 3 sets. So the point is we have a higher resistance for smaller mid-range number of reps, smaller mid-range number of sets. If we're trying to improve muscle power, we're going to do 20 to 70% of the 1 rep max for 5 to 8 reps over 3 to 4 sets performed quickly, because remember, power is time dependent. And so these are going to be more of our explosive movements. And because our explosive movements have more anaerobic use, we have an increased risk of fatigue. So we're definitely going to have a lower number of reps compared to our strength, but we may increase the number of sets so that we are getting still the total exercise volume that we're looking for. And if our goal is to improve muscle endurance, then we're going to have a lower intensity resistance, so 20 to 60% of our 1 rep max for 12 to 25 reps, so higher number of repetitions over 3 to 5 sets. And so that's going to be our mid-range to higher level of repetitions. Again, because the goal is to increase how much time the muscle can work over, we need to have lower force but an increased overall volume. We will also look at the order in which we tell our patients to do the exercises in, and the order in which we implement and progress them in order to get the best improvements and keep our patients safe. So we'll start with large muscle groups before we work small muscle groups. We'll do multi-joint exercises before single joint exercises, and higher intensity at lower repetitions before lower intensity, because typically we need to target muscle strength gains before we need to target muscle endurance gains. And our exercise frequency, the greater the frequency and volume of each session, the less frequently it needs to be performed, and vice versa. So if we have really vigorous exercise sessions, we don't need to do as many of those throughout a week as if we have low intensity exercise sessions. We should probably be doing that more regularly towards every day. Exercise duration is going to be dependent on what the patient can tolerate and what our goals are, but we also need to remember that clinically, most of the time, we're trying to treat a patient for at least 60 minutes because we need the billable time. And so we need to be sure to include rest intervals or recovery periods into our exercise so that way we're getting to utilize the most out of our time and getting our patient the most capable to withstand a 60-minute treatment session. The purpose of rest intervals is to allow for muscular recovery, cardiopulmonary recovery, and just overall giving the patient the ability to perform whatever the next demand is. We want to integrate rest into our exercises, but we also want to keep the patient moving as best we can because active recovery is more effective at neutralizing the effects of muscle fatigue than passive recovery. So if we have a patient do an exercise and then do a light stretch, or we have them do stairs, but then instead of sitting down, we have them walk a little bit to cool down from that functional activity, we are still keeping the person moving. We are still decreasing the intensity of the workload and providing rest in that capacity, but we're also keeping them active to reduce the likelihood of muscle soreness and promote better strength gains. How long should a patient rest for? Again, this is going to go back to what the patient's demands are, what their needs are, and what their goals are. The textbook and research supports 1 to 3 minutes for most patient populations, with more vigorous intensity exercise um, and lower level patients requiring longer rest periods than lower level activity or higher level patients. So 1 to 3 minutes is the range that you may or may not need to know for your test, but the real answer is that it's going to depend on what the patient can do. We're also going to look at the mode of exercise. A couple of different things that can factor into the mode. One of those is going to be the type of muscle contraction. So do we have a lengthening eccentric contraction? Do we have a shortening concentric contraction? Do we have an isometric contraction that's staying the same length? Which of those is going to be the most effective for our patient, and which is going to help the patient reach their goals fastest? The position for the exercise is going to be important because it's going to help us determine A, are they moving against gravity or is gravity helping them, and B, are they weight bearing or non weight bearing, and what's happening at the joints and muscle inhibition and muscle activation as a result of that weight bearing. Forms of resistance, we'll talk about those a little bit more here in a minute. The energy systems that the body has to use, is it an anaerobic or an aerobic energy system? The range of movement, the short arc or full arc, are we going through a partial range of motion or are we going through the full range of motion? And then application of function, how is this going to help the person in their day-to-day life? Pediatric and geriatric exercise programs should bias weight bearing whenever possible because for each population it has its own benefits. We'll talk about those when we go into those special populations a little bit more. But examples of our weight-bearing exercises are going to be things like push-ups, squats, sit-to-stands, heel raises, bear crawls, anything where we have closed chain weight bearing through the upper and or lower extremities. The velocity that an exercise is performed is also going to determine its effectiveness. So we have what's called the force-velocity relationship. For concentric muscle contractions, we tend to get more force with a faster contraction, but eccentric muscle contractions are typically the slower portion of the exercise and require slower motion to generate greater levels of force and greater levels of control. Application to resistance training means that exercises must be performed at the appropriate velocities to be effective. So when you have a patient who's sitting there supposed to be doing long arc quads, but they're swinging their leg up and down, that velocity is too fast to get the force generation that we're looking for the strength gains that we need. So we have to educate those patients to slow down through movement, that we can't move too quickly as a result of wanting to get something done or not being aware of the exercise. We have to move at a slower pace in order to see the gains that we're looking for. We can also use periodization and variation of training to where we will block things into different periods and cycle back to them so that we have on and off periods, or adding variation to where there's just a change every single treatment session that can help carry over in patients who do not have cognitive challenges but can be a hindrance to patients who do have a cognitive challenge. And like with everything we've discussed in this course, we have to have an integration of function. When we are increasing strength, we're going to have changes in function, hopefully an improvement in function, like our goals. But in order to achieve that safely, we have to think about carryover to the application of our resistance exercises to functional activities and train the neuromuscular systems that are needed to control those activities. So we have to have a balance of stability and active mobility. So can a patient maintain a stable position while also moving a limb segment? We have to have a balance of strength, power, and endurance so that we don't have a patient who functionally fatigues. And we have to have task-specific movement patterns with resistance exercise so that we are strengthening within the functional range and keeping the muscle with the neuromuscular control that it needs. And we have two main types of resistance exercise, mechanical and manual resistance. Manual resistance is going to be when you as the therapist are applying the resistance to whatever movement or exercise you're trying to have the patient do. Mechanical resistance is when you use equipment of some kind. So weights, therabands, those things can be considered mechanical resistance. Isometric exercises can be applied against manual or mechanical resistance, but that's where the muscle contracts and produces a force without visible joint movement. And these typically are our lowest level of contraction, but we use them to minimize atrophy, especially when a patient's being immobilized, to reestablish neuromuscular control and promote proper motor firing, to enhance postural and joint stability, and develop static strength at a specific range of motion, especially if a patient has a specific point in the range of motion where they demonstrate weakness, such as knee buckling with ambulation. There are several different types of isometric exercise. So we have muscle setting exercises, which are going to be probably our most commonly used in therapy. So when we think of quad sets, glute sets, hamstring sets, anything where we're squeezing the muscle, activating it for a period of a hold, and then having it relax, those are our setting exercises. We also have stabilization exercises where we try to have a patient hold a limb segment still against alternating external forces, so where they are working on stability and being able to resist against any kind of external force. And then multiple angle isometrics are going to be essentially setting exercises that we do at different degrees of range of motion. So a manual resistance is typically applied so that we can control the angle at which the resistance is applied, and take the patient from starting range of motion to as much of end range of motion as they have, stopping at different points along the way for an isometric muscle contraction. When prescribing isometric exercises, we have to consider some different characteristics. And so intensity of the muscle contraction, recommended intensity is going to be approximately 60% of their maximum muscle contraction. The duration of muscle activation, so for isometric sets, we typically do 6 to 10 second holds. Repetitive contractions, we typically do 3 sets of 15 for isometric contractions, though that can range from 10 to 20 depending on where the patient's starting point is and what the patient's goals are. The joint angle and mode specificity, so again, what is the point and purpose of the isometric contraction, and is there a specific range of motion that we need to target muscle activation, and is there a specific activity that they need to be doing to target that muscle activation for functional carryover? And then sources of resistance, how are we going to have the contraction resisted so that we ensure that there's no joint motion? Do we need to use manual resistance from the therapist? Is there some kind of device or equipment that we can instruct the patient to utilize so that they can provide that resistance with mechanical resistance, and whatever works best for the patient in their particular scenario? Diving into concentric and eccentric contractions, when we have joint movement or limb segment movement, we're typically going to have a concentric component to the exercise and an eccentric component to the exercise. And we as the therapist can step in and determine, okay, which portion of this contraction do I need to emphasize? Where do I need to place assistance, and where do I need to place resistance? Special considerations for eccentric training are that because of the neural connections that are made with eccentric training, we can use active eccentric contractions to generate muscle contractions and develop a beginning level of strength and neuromuscular control. So if a patient only has trace contraction or 1 out of 5 where you can just palpate it and they can't move through range of motion, you can move them through the concentric portion of that range of motion and then provide active assistive range to return where they have to control against the resistance or gravity to promote better muscle firing and activate that muscle to then carry over to the concentric muscle contraction. When determining which segment we need to emphasize and how we can best assist the patient and help them achieve their goals, we want to look at the exercise load and strength gains and where the patient's at, what we're trying to get them to, and which type of muscle contraction is going to get them there fastest and most effectively. We want to look at the velocity of the exercise. If it's something that needs to be performed more quickly, we probably want to emphasize our concentric contractions because that's how they generate more force. But if we're looking for control, we probably want to emphasize our eccentric muscle contractions and move more slowly. The amount of energy that is expended, it can depend on how much explosive power is needed from a fast concentric contraction versus how much control is needed from a slow eccentric contraction. But for each activity, we want to look at what the energy demand is and where we need to help target that patient's goals best. Specificity of training, we have crossover from both concentric muscle contractions to eccentric muscle contractions and eccentric to concentric, but we see that crossover happen sooner with eccentric to concentric, and so how much of that crossover do we really need? I'm sorry, I think I might have switched what I was talking about for cross-training effects and specificity of training. So that was all for cross-training effects. Specificity of training is going to be what is our functional goal and how do we train that muscle to specifically form the action or perform the action that's needed to achieve that goal and have the patient's functional performance improve. And then exercise-induced muscle soreness, what is the patient's risk, which is going to cause more? Typically, we see more exercise-induced muscle soreness following eccentric muscle contractions. But again, if we're worrying about more explosive power from our concentric contractions, then that can be an area where we see muscle soreness. And so we just need to pay attention to how our patients respond. When performing dynamic exercises, we have two different types of resistance that we can look at being applied. Dynamic exercise is constant external resistance, or DCER. That's where we're going to have the same external resistance no matter what the point and range of motion. So our free weights are going to be constant external resistance because it's a 5-pound weight in my hand no matter where in the range of motion it is. My variable resistance exercises are going to change the amount of resistance depending on where I am in range of motion. So therabands are an example of variable resistance in that the more taut they are pulled, the more resistance they provide. And so as a person moves deeper into range of motion, they're going to experience greater resistance to that muscle group. A more effective presentation of variable resistance exercises would be pulley machines that allow the resistance to change as the person moves through range of motion so that the torque that needs to be generated by the muscle remains constant through the range of motion. Those are clinically not used as often because of accessibility of equipment. But because the torque a muscle can generate changes depending on where it is in range of motion because of how much of the force is lost to traction or compression through the resulting vector, variable resistance changes to keep the torque the muscle generates consistent. Isokinetic exercise is iso being same, kinetic movement, so same movement. It has a constant velocity, and so these types of exercises require special equipment to utilize in which the velocity of limb segment movement is controlled by the machine. We can set a range and selection of training velocities depending on what the patient's needs are, and there's reciprocal versus isolated muscle training, so it can strengthen in both directions or on one side. And there's a specificity of training to where the range of motion and speed of motion is typically set depending on what functional needs the patient has. Isokinetic training can help to decrease compressive forces on the joint because it is trying to target the majority of the force at a rate that keeps it through the perpendicular to the bone instead of through the bone so that we're not losing force to compression or traction. And there's also an accommodation to fatigue because of the constant rate as the muscle gets to the weaker positions, there's less resistance that it is feeling, and so it keeps the torque constant as well. And we can also use isokinetic exercise to accommodate to a painful arc, but truthfully I would not stress yourselves very much about learning isokinetic exercises because we do not often use them clinically. Open versus closed chain. Hopefully we understand this to some extent by now, but they provide two unique approaches to function and exercise, and how we function can differ depending upper extremity versus lower extremity, in which we use more open chain motions and which we use more closed chain motions. Closed chain activities target multiple muscle groups and promote joint approximation and provides a weight-bearing stimulus to the muscle. And so I tend to be a bigger fan of closed chain movements because I think they have a better carryover to function. Some examples of our closed chain activities are going to include squats, sit to stand, step ups. Those are all lower extremity based, but we can do push-ups for upper extremities, planks, any of those types of things. Open chain targets are going to hit more isolated muscles and help to ensure joint stability prior to integrating multiple joints. So, if we know that we have a deficit at a specific muscle, we can target that muscle with our open chain motions to help improve stability before we get to our closed chain motions. But remember, we typically want to do larger muscle groups together before we target smaller muscle groups and multi-joint muscles before we do individual joint muscles in order to promote that stability. So there's a balance in how we walk those things in targeting what is most effective for that patient based on their presentation of weakness. When determining which exercise type to use, we can ask ourselves a couple of different questions. And so the first of those is going to be isolation of muscle groups. Am I trying to isolate a specific muscle, or am I trying to isolate a specific muscle group for function and purpose? And so typically, if I'm trying to isolate muscle groups, I'm going to focus on my open chain motions unless there is a deficit to a specific group related to function. When we're looking at control of movements, again, what are my patient's needs? Are they more in an open chain pattern, or are they more in a closed chain pattern? I can establish control of movement by isolating a single muscle activation, especially if I have therapist support, and so I may choose to pick more open chain motions there. Joint approximation, I definitely need to have closed chain motions because I need to have the weight bearing for compression in order to get joint approximation. Co-activation and dynamic stabilization, they can be performed in both open chain and closed chain, but we tend to get more activation of those those types of muscle activations through closed chain activities. But rhythmic stabilization through open chain can give us co-activation and dynamic stabilization. If we have proprioceptive, kinesthetic, or neuromuscular control and balance targets, then we're typically going to want to focus more on our closed chain because of the enhanced neural inputs from closed chain activities. And then carry over to function and injury prevention, again, depends on the functional needs of the patient, but typically is going to be more closed chain activity related. Implementing and progressing open and closed chain exercises, a lot of times we're going to start with open chain through our passive range into active range of motion activities. And so when we think of resistance training, we don't necessarily start with resistance to open chain motions. We typically are going to integrate closed chain motions in that so that we can carry over to function. But there are situations where we need more open chain training, and so that's going to be when we have specific isolated muscle weakness and we need know exactly which muscle we need to target. That can also be where we have edema that can be worsened with joint compression and weight bearing, and so we need to have joint weeping occur through range of motion activities while also trying to promote strengthening in the muscle, and so we can utilize resistance exercises and open chain pattern for that. Or if our functional needs require open chain movements like reaching overhead for something out of a shelf, and we need the upper extremity strength to be able to do that. Closed chain exercises and weight bearing restrictions are going to cause difficulties with performing closed chain exercises, and so we can use unloading. When we're looking at upper extremity unloading, that tends to be easier because we don't bear our weight directly over top of our upper extremities. When we lean on them, the amount of weight that we're bearing through them is dependent upon how parallel to the ground we are. So the more perpendicular to the ground or the more upright we are, the less weight we would bear through our upper extremities if we put them in a supporting position. But if we lean forward, such as leaning on a table, then we start to put more weight through the upper extremities, but not as much weight as we do when we're completely parallel to the ground, like in a push-up position. And so we think of unloading as how can we integrate weight bearing through the joints without it being 100% of body weight. We can do this to the lower extremities with special equipment, like utilizing a leg press instead of sit to stands, where we can set the weight, or we can try to utilize reclined positions. But again, because of the design of our body and upright structure and positioning of our lower extremities underneath of our axial skeleton, it's more difficult to apply unloading to the lower extremities. The most effective way is probably when we weight shift over to one side, where all of the weight bearing happens through one lower extremity, and then we can modulate how much weight is placed through the other lower extremity. If you look in Table 6.9 on page 203 of your textbook, it talks about the progression of closed chain activities. And so if we look at our different parameters, We can progress closed chain activities by addressing each of these parameters individually or several of the parameters as a whole, eventually trying to get to the functional activity. So percent of body weight, how much are we having them weight bear and how can we modulate that? The more weight that we bear through a joint, the more difficult the task becomes, and so we start out with partial and progress to full weight bearing. The base of support that's provided, we start with a wider base of support because that provides more stability, but we increase the challenge by narrowing the base of support. The support surface is obviously going to be easier to accommodate to when it is a stable, firm surface, but we can make that an unstable surface in order to provide greater challenge to the patient as they progress. Balance, whether or not we're providing external support, can they lean on something, do they have upper extremity support, or have we taken that away? Excursion of limb movement, so if we are keeping the limbs still and just trying to maintain position, or have we superimposed limb movement into an activity? Are we making it a single leg stance with a march on the opposite leg where we now have limb activity, or is it a double leg stance where we're incorporating trunk rotation so that we have our arms moving to reach to the left side for something, passing it to the right side for something? Each of those elements of limb excursion is going to increase the difficulty of the closed chain activity. The plane or direction of movement, if we stay in a single plane of movement, that tends to be easier, but as we need to increase the challenge for patients, we change how many planes they're having to move in, and so the more planes that we move in, the greater the challenge to the patient. And the speed of movement or directional changes. Slower movements are easier to control, but as we need to challenge the patient more to see a greater progression, we increase the speed at which those challenges are activated or the activity needs to be performed. General principles of resistance training. So for exam and eval, we want to make sure the patient is safe for resistance exercises, that there's nothing that's going to be harmful to them by performing resistance exercises. And we want to ensure that we check vitals as appropriate. So we might want to double check in our chart review for things like hypertension, because those patients are going to be at increased risk when performing resistance exercises. And so checking their vitals and understanding what their baseline is can be important. When preparing for resistance exercises, we need to consider our patient's stage of motor learning for the task. How much do they know about doing this, and how much are we going to need to cue them and make sure that they're doing it correctly and staying on top of them versus being able to tell them what to do and walk away and check on another patient. We also want to consider how we're providing the instruction and what the environmental distractions are like. The level of learner of the patient will often dictate how much distraction they can handle and how much attention they require. And so keeping those things in mind can be really important for patient safety. When implementing resistance exercises, we want to give patients a warm-up and a cool-down so that we can decrease the risk of exercise-induced muscle soreness and the risk of injury. We want to consider the placement and direction of resistance. Resistance does us no good if it is applied in the opposite direction of the muscle that we're trying to resist. So if it's assisting the muscle that we're trying to strengthen, we are not performing resistance training. And so we have to pay attention to the placement and direction of our resistance. Stabilization is important, whether or not we need to provide external stabilization to the patient because they can't, or if they're able to maintain the stable posture and alignment of the joint, but we want to make sure that the activity can be performed correctly. We're going to think about the intensity and the amount and the number of reps and sets and rest intervals, and we're going to make all of those decisions based off of our patient's presentation and what our patient's goals are. We're going to consider whether we provide verbal or written instructions, understanding the stage of motor learning that the patient is in and how each can affect the patient's ability to understand and then accurately perform the exercises. And how closely do we need to monitor the patient? Are they a new learner and they need frequent cues and feedback so that we have to be there throughout every rep of the exercise? Or are they developing in their learning stages and they're able to receive instruction and appropriately and safely perform the exercise without constant monitoring? Precautions for resistance exercise are going to include monitoring patients for Valsalva maneuvers, so that's that bearing down that can happen when trying to generate force through the muscles. And what happens is that stops blood supply from the inferior vena cava returning to the heart, and then upon release of that bearing down, the blood rushes back to the heart and can cause a cardiac event. So this is risk prevention during resistance exercise, and we can prevent patients from valsalvating during resistance exercises by ensuring that they breathe. We can have them count out loud because if you're talking, you're breathing. And so anything that promotes active attention to breathing and ensuring that that's happening during resistance exercises will help patients prevent valsalvating. We also need to look for substitution motions, ensuring that we are not allowing patients to utilize compensations to complete an exercise, that we are getting appropriate activation of the muscles for the goals that we are trying to reach, and that the substitutions don't put them at greater risk of injury. We also need to avoid overtraining and overwork. Overtraining would be pushing them too far in their training sessions and having fatigue that accumulates over time, or overwork would be typically within one exercise intervention and trying to push through poor performance as a result of fatigue. If a patient demonstrates fatigue in one muscle group, transition to an exercise that rests that muscle group and works another muscle group before returning to that exercise, but don't just abandon ship. We'll also be on the lookout for exercise-induced muscle soreness, which can include acute muscle soreness happening during the time of exercise performance, and delayed onset muscle soreness, where the patient doesn't experience muscle soreness during exercise, but will experience the development of soreness later on. We can prevent this by promoting patients to move following therapy so that they do not get lactic acid buildup, but they can have muscle pumping and joint weeping, and also promoting hydration so that those things are cleaned out of the body. And we also need to pay attention for pathological fractures that can recur as a result of resistance training. So patients at risk for this are going to be patients with osteoporosis, where we have decreased bone density, and we need to ensure that we do not apply excessive amounts of resistance that result in pathological fracture. Contraindications to resistance exercise. So pain is going to be what we'll consider a relative contraindication, because we can't let pain always stop us. Sometimes resistance exercises can help alleviate pain, but we have to monitor the patient's response. We don't want our resistance exercises to increase pain, and we also need to monitor for that onset of pain as a symptom of muscle fatigue. Inflammation is going to be a contraindication to resistance exercise. So if we have inflammatory neuromuscular disease in active inflammation, inflammatory muscular disease in active inflammation, or acute joint inflammation, we want to avoid resistance exercises. And severe cardiopulmonary disease, we want to avoid resistance exercises so that we don't put undue strain on the lungs and heart. Manual resistance exercise is going to be when the resistance is applied by the therapist, and so we need to pay attention to our body mechanics when we're applying that resistance so that we don't put ourselves at risk of injury. We want to make sure that we apply the manual resistance in the direction that we need to apply it, and that we are stabilizing if the patient is unable to stabilize independently. We want to provide verbal commands so that the patient understands what to do and they're able to complete the exercise appropriately and safely. And we need to make sure that we communicate the number of reps and sets and rest intervals and make that determination for each patient based off of their presentation and their goals. You can take a look through the upper extremity and lower extremity manual resistance techniques in the textbook and check out the videos online, and we will practice those things in lab. PNF is an approach to therapeutic exercise that combines functionally based diagonal patterns of movement with techniques of neuromuscular facilitation to evoke motor responses and improve neuromuscular control and function. It was introduced in the 40s and 50s and involves multi-joint, multiplanar, diagonal, and rotational movements of the extremities, trunk, and neck. PNF patterns tend to replicate functional patterns more readily, and so they can be implemented into resistance exercises as the patient demonstrates appropriate stability. We utilize those diagonal patterns because they relate to our functional needs better. And so we have D1 flexion and D1 extension of the upper extremity and lower extremity. And we have D2 flexion and D2 extension of the upper and lower extremity. I will give you guys handouts for those in class, but again, PNF stuff we will cover more thoroughly in neuro. But basic procedures with PNF, we want to consider our manual contacts, so we keep our hands over joint lines, trying to avoid muscle belly contact. Maximal resistance should meet the patient's needs and not exceed the patient's ability. Position and movement of the therapist should be in a way that we consider body mechanics as we move the limb segment through the entire diagonal pattern, and that we have good control of the limb segment. And normal timing is going to be related to function and what we require for muscle firing timing for execution of functional tasks. PNF techniques include rhythmic initiation, where the therapist passively moves the patient through the diagonal pattern, allowing them to progressively take over into an active assistive range of motion through the diagonal pattern until the point that they're able to take over the pattern with an active range of motion. Repeated contractions is where the therapist will take the patient through a diagonal pattern, stopping for intermittent isometric contractions throughout the range of motion. Reversal of antagonists is going to be where the therapist applies resistance through one direction of movement and then switches hand placement to resist direction in the opposite movement of the diagonal. Alternating isometrics are going to be a resistance where the therapist provides resistance to simulate an isometric contraction in alternating directions to focus on stability. And rhythmic stabilization is again going to be where a limb segment or body is held in a stable position as the therapist provides perturbations or resistance from multiple directions to enhance the body's neuromuscular response. Mechanical resistance is when we apply resistance through some piece of equipment, whether that's a free weight or a TheraBand or a weight pulley system, whatever that may be. And there's application for them in rehab programs and in fitness and conditioning programs. Special considerations for resistance training, especially with mechanical resistance in children and adolescents. Resistance training is safe and effective, but utilizing body weight in a closed chain as that source of resistance will contribute to program safety. There are specific resistance training regimens that you can try with your patients depending on their needs, presentations, and goals. Progressive resistance exercise is where we are going to progressively increase the resistance that the patient is experiencing. There's DeLorme and Oxford regimens and the DAPR regimen that you can read about in your textbook should you care. But these are recommendations for progressive resistance training protocols that you can use as a starting point, but your exercise prescription should always be patient specific. There's also blood flow restriction, which is good for a very specific patient population, specifically the athletic population, where blood flow is restricted to the musculature while the muscle works in order to promote enhanced strength gains. There's circuit weight training, which adds cardiovascular component to exercises when performed correctly because it keeps the aerobic heart rate up as you move through the circuits. The exercise order should rotate between muscle groups following recommendations to exercise order previously given, so where we target large muscle groups before small muscle groups, multi-joint muscles before single joint muscles, but alternating between muscle groups allows the patient to have recovery time while they work a different circuit and keep their activity level more continuous so that they can maintain that elevated heart rate for the aerobic carryover. Looking at free weights and simple weight pulley systems, these apply the maximum exercise load at the maximum torque position, and so strength gains are going to be variable through the range of motion. The advantages and disadvantages are going to be patient dependent. The ability to put a patient in multiple positions with either free weights or a pulley weight or a weight pulley system is going to be beneficial for some patients, but it might be too much to control for other patients, and so we have to utilize judgment there. We have varying degrees in the selection of resistance, though we tend to have larger increments with our weight pulley systems than our free weights. And so how much we need to modify the intensity and the force that the patient needs to be able to generate can factor into which of those systems we select. And safety concerns, what's going to be the safest for the patient to attempt to utilize to prevent risk of injury from intentional use of the equipment or unintentional use. Variable resistance units use hydraulic and pneumatic resistance devices to create a consistent torque throughout the entire range of motion. Advantages being that the resistance adjusts to match the muscle's torque, but the disadvantages being that you typically are restricted to single plane movements which do not have the same carryover to function. Elastic resistance devices are going to be things like our TheraBands and our TheraTubes, where they stretch to apply resistance. There's goods and bads for that. They tend to be cheap, effective, and easy to hand out to patients for increased compliance with a home exercise program, but they have a variable presentation and resistance because as we stretch the elastic farther, the resistance increases. And so the effects of elongation of the elastic material is that we get increased resistance with elongation. We also have a hard time to determine and quantify the exact amount of resistance. We have a color coding system that we utilize, and so we know that Certain colors are more resistance than other colors, but again, as that resistance is variable, how much tension do you have when you start to pull that band? How close are they starting to the position of which the band's being stretched from? So is there more elasticity to work with, or is there greater force production and resistance because they're starting closer to the attachment point? And so it's hard to exactly quantify the amount of resistance being utilized when we use elastic resistance devices. And then fatigue characteristics of elastic products raise a safety concern because as they are used over time, they have little micro tears in the elastic that eventually can cause the bands to snap, and that can cause safety concerns for our patients. When utilizing resistance bands, we want to consider that we pick the appropriate grade of material, so the right color for the right level of resistance for our patient. We want to make sure that it's the appropriate length, that they have the sufficient elastic band needed to complete whatever the activity is. We need to make sure that there's a way to secure the bands or tubing in a way that won't dislodge while the patient's performing the activity and cause injury. We need to make sure the exercise is set up in a way that the resistance is pulling from the correct direction, and how we can progress those exercises both within the same color of band and moving to the next color of band. So we just need to consider all of the advantages and disadvantages when utilizing elastic resistance as our means of resistance. Dynamic stabilization means that we are implementing more movement that the body has to stabilize against. And so we have some special equipment that we'll be able to play with in the lab for dynamic stabilization. That's going to include the body blade, which we will typically utilize for shoulder stability. We will get to more in the shoulder joint chapter. Swiss balls or stability balls, again for trunk and lower extremity balance and stability exercises, but changes the stability of the surface so that there is more movement that needs to be controlled against. And Bosu balls are going to be the half ball, half flat surface that we can use for upper or lower extremity activities, and again changes the stability of the surface so that we have to control the body more. Equipment for closed chain training can include specialized exercise equipment or multi-purpose exercise systems that can target various areas depending on setup. Slide boards, different than the slide boards you guys utilize for transfers. These are going to decrease the stability between either the upper extremities and the ground or contact surface, or the lower extremities and the ground and contact surface, which then requires greater muscle activation to maintain proper form for the patient. We have different balance equipment that we'll try out in the lab, including the Bosu ball, the AirX pads, the AirX beam, all of that stuff. And then the mini trampolines or rebounders we can also use for closed chain training. Reciprocal exercise equipment allows us to have bilateral extremity involvement, where the extremities are going through the same motion but at alternating times. So examples of our reciprocal exercise equipment are going to be our stationary exercise cycles or our new step machines, which are basically like a seated or recumbent elliptical. Portable resistive reciprocal exercise units, equipment combining upper and lower extremity resistance, stair-stepping machines, elliptical trainers and cross-country ski machines, upper extremity ergometers. We do have a UBE in the modality closet, so if we want to check that out to understand what reciprocal movement looks like, we can do that during lab. I'm going to go through a couple of questions here to wrap up, just to give you guys a knowledge check. I'm not going to pause as long after the question, so if you would like to pause before the answer, go ahead and pause the video independently. After these slides, I do not believe I have a wrap-up slide, so keep in mind that before the next class, I'd like for you to make sure that you have access to your textbook resources, including looking at the figures in the videos. Best preparation comes from reviewing those things prior to lab. Also, make sure that you have clothing prepared for our lab day for performing resistance exercises with all of your classmates, including being the therapist and the patient. And make sure that you write down any questions that you have over this chapter so that we can discuss them before we get into lab activities. Question up. Which of the following resistance training methods is specifically designed to improve muscular endurance? A, circuit training, B, plyometric exercises, C, 1 repetition max testing, or D, static stretching? And the answer is A, circuit training. Circuit training involves performing a series of exercises targeting different muscle groups with minimal rest in between. This method aims to improve muscular endurance by challenging the muscles to sustain activity over an extended period without excessive fatigue. During a resistance exercise session, a patient experiences sudden sharp pain and swelling in their elbow joint. Which of the following actions should the PTA take first? A. Continue with the exercise session to assess the severity of the pain. B. Apply ice to the affected area and elevate the arm. C. Have the client perform gentle stretches to alleviate the discomfort. D. Stop the exercise immediately and assess for signs of injury. Answer D. Stop the exercise immediately and assess for signs of injury. Sudden sharp pain and swelling during a resistance exercise session could indicate an acute injury, such as a muscle strain or ligament sprain. Stopping the exercise immediately and assessing for signs of injury is crucial to prevent further damage and ensure appropriate management.